have a couple just in case no one asks anything. Or
yep, sounds good.
Okay, I might just get started, and hopefully we've got a few more people joining while I'm talking. I'm Sarah Green. I'm the Executive Officer of the Health Services Research Association of Australia and New Zealand. Thank you for joining our webinar this morning. I'll just start by acknowledging the traditional owners of the lands upon which we meet and pay my respects to elders past, present and emerging. The association was set up to facilitate networking, education and training and build capacity in health services research in Australia and New Zealand. These webinars are run once or twice a month, and they are free, but we do ask, if you're not a member, if you would just take some time to have a look at our website, HSRAANZ.org, and think about joining. One of the key reasons to join is our Health Services Research Conference, and our next conference is being held on the 1st to the 3rd of December this year in Sydney, and members receive a good discount for registration for that conference, so it is a very good reason to join. Call for abstracts for the conference is open and closes on the 6th of June, and all the information about that is on our website as well. And it will be a face-to-face meeting, fingers crossed, with some virtual offerings that we're still working on. Just a couple of housekeeping issues this morning. Jason will talk for about 40 minutes, and then we'll have Q&A at the end. And if you have any questions during the presentation, you can type them in the Q&A button, and the chair will put them to him at the end. I'm recording the webinar, and that should be on our website by tomorrow morning. I'm going to hand over to Alison Pearce, and Alison is the Association's Public Officer and a very active member of our executive team and a health economist at Sydney University, and she'll introduce Jason and manage the question and answer session at the end. I'll switch my screen and my microphone off and hand over to Alison.
thanks, Sarah, and welcome everyone to the webinar. I'm really excited to be here today and to introduce Jason, who's Associate Professor Jason Ong is an academic sexual health physician with a passion for research amongst marginalised populations. So he's based at the Melbourne Sexual Health Clinic, but also has some joint appointments, including at Monash University, the University of Melbourne, and the London School of Hygiene and Tropical Medicine. And Jason is uniquely placed with his combination of skills and experience as both a clinician and a health economist and an epidemiologist. So he brings a really unique perspective to a lot of his research questions. And he really focuses his research on giving a voice to the voiceless, and enjoys sort of the challenge of shining a light on taboo topics and helping make better decisions in those areas. And the work that he's presenting today was actually the winner of the 2020 Best Paper Award by an early career researcher, which was awarded by the Health Services Research Association of Australia and New Zealand. So it's really exciting to be able to hear Jason speak about this research today. As Sarah said, I'll hand over to Jason now to give a presentation, and then at the end there'll be an opportunity to ask questions and discuss. If you've got anything that comes up during the presentation, maybe just put it in the chat, and at the end when we open up for discussion, I'm happy to take questions either through the chat or for people to ask questions with their voice and video. But for now I'll hand over to Jason, and I'll turn my camera and microphone off too.
Thanks so much, Alison and Sarah, for the introduction and also the opportunity to present. Thanks for those who joined us live, and I hope that the talk today is of interest and or helpful in your own research as well, in new ways of thinking about any of your research. So the topic of today is, I'm going to share a paper that was published on the global epidemiology of sexually transmitted infections among users of PrEP to HIV. So I'm presenting this on behalf of a large team kind of spread around the world, from the London School, also from the US, and also the WHO team in Geneva who funded the project. So in terms of conflicts of interest, I don't really have anything to declare. The only thing is just the funding that we received from WHO, who commissioned us to do the systematic review. So today I want to give a talk using this structure. So a bit of background for those who are not familiar with this area, the aims of the project itself, the methodology that we used, and some of the results that came out of this. So in terms of a bit of background, so we know that HIV is still one of the other viruses that is causing a big pandemic, and in fact, a lot worse than COVID. With last year alone, 1.8 million people were newly infected, and still a lot of people are dying, like millions of people are still dying each year. So however, we have now the technology and the ability to prevent HIV. And one of the most exciting game changers is one called PrEP, or pre-exposure prophylaxis. In other words, people are able to take the medication and also be more than 99% protected against HIV. So WHO has been advocating for this since 2016 onwards to try to scale up PrEP. But at the same time, we noticed that there was actually a concerning rise of STIs being noted among certain studies who were researching people using PrEP. So we noticed that there were high incidence as well as prevalence. And people started to worry about using this term risk compensation. So if people are now knowing that they're protected against HIV, are they now risk compensating to not use condoms? And because they're not using condoms, they're going to be at higher risk for sexually transmitted infections. And kind of tying into this is this whole problem of antimicrobial resistance as well. So we know that around the world, not just for STIs, but many antibiotics are becoming resistant. Many bacteria are becoming resistant to antibiotics. So there's this concern that if we don't do anything about STIs, it's going to continue to be a problem. So I guess this question arises thinking about, are you kind of a half full person, half glass full kind of person, or half empty kind of person? So I guess with the half empty, you could kind of point the fingers at them and say, is PrEP actually contributing to this rise of STIs? But if you're a half full kind of glass kind of person, you could take this as an opportunity, because in a sense, people with very high STIs are coming into services that are being prescribed PrEP. And therefore you have an opportunity now to reach people who are at very high risk and do something about their either sexual behaviors or protect them against STIs as well. So with this kind of background, WHO wanted us to do a systematic review to understand, could PrEP actually be that gateway to empowering better sexual health services for PrEP users? So we want to be able to harness these opportunities for regular visits, because these highly vulnerable populations are now coming in every 3 months, where in the past we could, very difficult to find them or even engage them in healthcare. And so at that kind of 3 monthly visits, then we have now opportunities to do the regular testing, talk about prevention services, including vaccinations, do the counseling that we couldn't do before, and also address other more holistic aspects of the health, so mental health, drug use. And I kind of mentioned antimicrobial resistance as one of a possibility as well. So the aim of the project was to firstly determine the baseline STI prevalence of PrEP users, just to be an advocacy point to ask for better STI services or sexual health services amongst these PrEP programs, and also to determine the incidence of STIs as well, of PrEP use. So is there an ongoing risk of people using PrEP and still getting STIs along the way? And also, alongside the systematic review, we actually were quite interested in looking at what kind of barriers and opportunities the actual providers are facing when they try to integrate STI services into their PrEP programs. So in parallel with the systematic review, we actually also did a global survey amongst PrEP users. So in terms of the methodology, as I mentioned, there are two sources of data, kind of bread and butter systematic review, as well as a survey from the PrEP implementers. So we searched 9 databases and using 2 key concepts, so one around STIs, one around PrEP itself. And as I said, it was nothing deviant to the usual systematic review, so we followed the guidance from Cochrane. So in terms of inclusion criteria, we included RCTs, observational or demonstration projects, anything that had a lab-confirmed STI incidence or prevalence. We also tried to look for cost data or economic evaluations, and also the description of their program itself. So we looked at all STIs. So this is just a list of the common ones that could infect someone. And we used a meta-analysis using a random effects model. So as I said, the primary outcomes were looking at the prevalence at baseline, so on enrollment to use PrEP, but also the incidence as well. So whilst they're using PrEP, is there new infections along the way? We were quite interested in doing some subgroup meta-analysis, so looking at people who, or places which may have higher incidence or prevalence of STIs. So this study was actually, this is the second part of our study. So this is for the data from the PrEP implementers. So we sent around a survey at the end of 2018 to 82 contacts. And also we basically asked them for any kind of STI prevalence or incidence that has not been published, but at the same time we asked them about their barriers or opportunities. So I'll present some of that data today. So on to the results. So we sifted through 3,325 citations initially and ended up with 88 that we could include in our meta-analysis. And this is just a little cartoon to show you the places that the publications came from. And this is very similar to, this is a group or a website called PrEP Watch. And basically they monitor which countries around the world is prescribing PrEP. So if I kind of flick back and forth, you can see that in terms of the countries covered, we did manage to cover most of the countries that were prescribing PrEP. So this is just a bird's eye view of some of the studies that we found. So importantly, at the time of our research in 2018, we saw that more than half of the research was quite recent, so within two years of our search itself. You can also see that, importantly, we captured non-MSM populations who are using PrEP. So MSM, or men who are sex with men, have the highest risk for HIV. And so a lot of the PrEP programs have been focused on them. However, there are also other populations such as adolescent girls, young women, IV drug users, transgender women, and so on, who also need PrEP. And so we were quite pleased to be able to capture them as a population. You can also see that rather than being randomized controlled trials, they started to have a body of evidence coming from actual routine implementation, so real world kind of studies being published, which was also very pleasing because this obviously is more generalizable as we roll out PrEP. And you can see that although PrEP is quite expensive, so it's being rolled out predominantly in high income countries, but we were also able to capture information from low middle income countries as well, which actually, because of health disparities, they actually suffer the highest burden of STIs. So it was very important to capture data from them. So I'm going to compare our results with this other paper. This paper is one also commissioned by the WHO, trying to look at the prevalence and incidence of anyone who's sexually active. So they don't have to be on PrEP. So this served as quite a nice reference point for us. So this is the kind of what's the background prevalence of sexually transmitted infections, and then is it very different from people who are using PrEP. So this is, firstly, you can see this is the Rowley paper. So this is the background prevalence. So these are people aged between 16 to 50 who are sexually active. What's their pooled prevalence of STIs? So on the left here, you can see the actual pathogen itself. So chlamydia is a very common bacteria, bacterial STI, gonorrhea, and syphilis. So you can see those kind of prevalences there. So I don't know whether in your mind, you just want to think how different would PrEP users be before I unveil this. Okay, so here's our results. So you can see that there are manifold higher prevalence compared to the kind of background. So in a way, this means that we are capturing a very high risk group for STIs, people who are starting PrEP, which in a way is a good news kind of message, because it means that we are actually reaching the people that really need to be reached, people who are getting a lot of STIs and therefore at risk for HIV. So at prevalence, having a high STI is good because it means we are targeting the right people. But you can see that it is very high. So probably 1 in 10 would have chlamydia or gonorrhea, and syphilis probably 1 in 20. And you can see that even for syphilis, it's like 10 times higher than the kind of background prevalence there. So it's, I'm sure as researchers, I mean, you can spend years or a long time, and you can kind of reduce your blood, sweat, and tears into one slide. But this is essentially what we did. We spent a lot of time, and basically this is one of the main summary slides. Within our paper appendices, which I'm not going to share today, we did a lot more digging into the heterogeneity behind the prevalences as well. So we looked at not just by pathogen, but we looked at anatomical sites, whether there's differences across different anatomical sites. As I said, we were quite interested in people who are not MSM as well. So we broke it down by that. And also looked at the type of study, the routine kind of implementation versus more trials kind of studies, and also by income level as well. So I think it's about 100 pages long, my appendix. So for people who really want to dig deeper into this area, you can look at the appendix for that kind of more the nuanced messages. And also within there, we've got the meta regression and the funnel plots as well to check for publication bias. So I'm just going to show you some examples of what we have in the appendix. So this is for gonorrhea prevalence. The font is probably quite small, but I just want to show you the differences that could happen by site. So this is gonorrhea prevalence by anatomical site. At the top is kind of all sites, but you can see that as you go to different ones. So this is the rectal one compared to the oral. So if you're focusing your eyes on the diamond shapes, these are the pooled prevalences. So, and this is the urethral. So you can see that if we actually dug down into the anatomical sites, they are quite different. So this is important because of management choices. So this is one example of our kind of sub-analysis looking at the country income level. So you can see, actually, surprisingly to me, the high income ones versus the low middle income countries, the gonorrhea prevalence, at least for is not significantly different from each other. This is by study type. So you can see, again, those who are in the real world, this routine ones, this is a bit larger, although it kind of crosses. So it may not be significantly higher, but you can see that in general, the trend is much higher in the routine or real world kind of studies compared to RCTs, which tend to be a bit lower. And then the cohort studies are kind of in the middle, and the demonstration projects as well. This is an example of a meta-regression result. Again, just highlighting the differences between anatomical sites, looking at populations, and looking at country income level, and also the study types as well. So in this specific scenario, you can see that the trend is for this, the anatomical site might be slightly different. And this is the funnel plot, just to show that there is lack of publication bias in this case. So here's the other kind of slide that's collapsed into, my blood, sweat, and tears collapsed into one slide. So this is the pooled STI incidence. So again, you can see on the right-hand side, I've given you a reference point. So this is again, the global estimates of all sexually active men and women as a background. And again, in your mind, I guess, maybe I've already primed you to think what the result could be. Have a think of, how high or similarly, or how similar would the PrEP population be. So this is the unveiling. So again, you can see, unsurprisingly, that the pooled incidence, so this is the number of new infections as they take PrEP, is a lot higher than the background. So chlamydia, gonorrhea, and syphilis are very, very high. So the limitations of the systematic review is that most of the STI data did come from high-income countries, so about 70%, and a lot of that is actually from the US. And this is not of surprise, because a lot of the PrEP work was done, was published from the US, and also in high-income countries as well. So there are some data gaps from other parts of the world, so we have to be careful to extrapolate our data into those settings. There could be some selection bias as well in terms of how people record their STIs. For example, I've given an example here in the US and even in Kenya as well, where having an STI is actually an indication to be prescribed PrEP. So perhaps that is, that funnels people with STIs into taking PrEP, so that could affect our prevalence rates. It doesn't happen for all the studies. So it's, for example, in Australia, we don't really use that as our inclusion criteria. So it kind of dilutes this effect potentially. There's also a risk of what we call detection bias. So because we are testing these people every 3 months for STIs, it does mean that perhaps we can pick up more a high incidence, given that a lot of STIs are asymptomatic. So unless you're testing for it, you may not find it. So that's another thing to be aware of, that this could artificially increase our detected incidence. And also the other limitation, as for those who may have been involved with systematic reviews in the past, is just a lack of a clear uniform measure. And this is something we have to wrestle as researchers in terms of getting a proper working definition that could fit or kind of use the data that's presented in the studies and trying to kind of make it more uniform. There was also an issue about inaccessible data. So as PrEP is being scaled up, people are collecting this kind of data, but they're not publishing it. So there was still behind the locked doors, I guess. And our hope was that many of this will be published in the coming years. And actually, since our review at the end of 2018, we've been pushing for more publications, and actually there has been more publications coming out. So that's a plus. So that's the systematic review, but I'm going to move on now to the survey that we sent out to the actual implementers and ask them questions around barriers and opportunities. So this is kind of shifting focus now to the service delivery side, and how do we actually deliver STI services now that we know that there's such a high prevalence and incidence. So we had 87 articles with STI program data. Yeah, so you can see that a large proportion also came from routine implementation and demonstration projects. Sorry, I need to correct myself. So this is still coming from our systematic review, but after I present this one, I will show you this global survey. So from these papers, I guess we could see that a bit more about how is PrEP delivered, how's STI services integrated, and you can see that the majority of PrEP was actually from the hospitals or from sexual health clinics, one thing we're trying to do is decentralize PrEP. So we're trying to move them more into the communities, but you can see that the majority of our data comes from hospital clinics. And in terms of integration, we were pleased to see that there was STI testing that was integrated directly into PrEP programs as well. However, it's in some cases, it was not always in the same site. So in other words, if you got your PrEP, they would say, oh, now you have to go down to the next building or down a few levels and go to a different department and get your STI testing. So in that kind of transition from one site to another, we found that many patients would disappear, like they wouldn't go for the STI testing. So that's fortunately in the minority, but it's still happening. In terms of frequency of testing, it's a bit of a hodgepodge out there at the moment. And this, again, it's something WHO is trying to be more proactive in leading the world to say, you know, how frequently should you be testing for STIs? But you don't have to look at the specific details here, but it's just to give you an indication of how different programs are in terms of testing, the frequency of testing for each of these pathogens. And similarly with the anatomical site as well. So we know that especially for men who have sex with men, they need to be tested in 3 anatomical sites. So the pharyngeal, the rectal, and urethral. Otherwise, you're going to be missing STIs. So sadly, we saw that the minority of people were offering triple site screening, and this is predominantly because of costs. And then some were offering only double sites, and some were just single sites. In terms of AMR, it's not the focus of my talk today, but it's also sadly, we did not see a lot of these PrEP programs using this opportunity to test for antimicrobial resistance. But the caveat here is that they may not explicitly mention these in the publication, so they may actually be underestimates. So at the end of the day, having looked at all the 87 studies, and I came up with this typology of how well PrEP programs have integrated STIs. So at the very, very top here, the best, the gold standard is one from the UK. So it's called the Dean Street Express, where essentially it's a rapid testing for point of care testing for STIs. So you go in for your PrEP, and within 90 minutes, you also get your results for STIs. So this is a really cool kind of program. So I was fortunate to spend a few months working there as well. So I could see firsthand how well this program actually works. Underneath that is the Australian system, I guess, where a lot of our PrEP is already delivered through sexual health services. So it kind of, everything is a one-stop shop. So we are able to integrate STI testing very well into PrEP programs. Kind of in the middle here is some countries that do have very minimal STI screening, and this is predominantly driven by costs. For example, some countries may only test for syphilis and no chlamydia or gonorrhea. And obviously at the very bottom of the typology here, that there are unfortunately PrEP services that has no services, STI services at all. So that's how we are starting to, I guess, think about the categories of PrEP programs. So I'm going to move on to the barriers and facilitators. So as I alluded to, this came from our global review as the survey. And I'm going to, so this was a thematic analysis. I'm going to share with you some of the major themes around the barriers and the facilitators. So the main barrier was also with regards to the diagnostic itself. So there is a lack of really highly sensitive, true point of care testing. So the one that I was talking to you about before in the UK, it is a point of care test kind of, but it does take about 90 minutes. So people need to go away and then come back for results, or we send them their results within 90 minutes. It's very expensive. That's the Gene Expert platform. And to get the truly kind of point of care within 30 minutes, we're still working on this. It's very difficult. And the ones that we have tested have very poor sensitivity and specificity. And also the other thing about the diagnostic is that there are a lot of these tests, they're not approved for certain anatomical sites yet. So in fact, labs who are using these rectal swabs and pharyngeal swabs, they're kind of using it off-label. So that's a problem. Another barrier is the actual logistic of itself in delivering PrEP. So I talked about the kind of trend to decentralize PrEP so that we can get this away from hospitals into communities where people are more easily able to access PrEP. And particularly if you can think of the types of people that really need PrEP, they don't want to come into a hospital itself. They don't, for lots of reasons. But because we are decentralizing PrEP, it does mean that these are provided by lay providers. So then we face this issue of how do we give injectable antibiotics by lay providers, which is impossible. We can't do that. So these are kind of program logistics. The other thing is that, some PrEP programs are not actually asking about STI symptoms at all. And also PrEP providers have kind of complained to us, we're just here about PrEP. We want to reduce HIV. We don't really have time for STI testing. So we see this being reflected in a lot of the services, especially the low middle income country ones. Another kind of barrier is just capacity building itself. So very simple things like a good light source or even equipment, a bed to examine was also seemed to be a barrier for a lot of services because they don't have that. And for those who may have worked in low middle income countries, they're very different. I mean, sometimes you could have like 10 people surrounding a table and you're taking intimate histories, and a genital exam is impossible in that kind of scenario. So these are very, very real barriers, and also the training of these PrEP providers as well. We also asked about some facilitators, like what could help improve the delivery of STIs. Money came out as number one, as in a lot of things. So in terms of reducing the cost of STI testing is needed. Some people talked about regional bulk purchasing. I know that has happened to some extent, but not to a significant extent as yet. This is a problem not just for low middle income countries, but also for high income countries as well. Even in Australia and New Zealand, testing someone for STIs is very expensive. I'm just thinking of people who don't have insurance. They're usually out of pocket $200 plus Australian each time they want to test for an STI. And so, so having the financial support to provide these kind of extra STI services as well is very costly. So thinking about counseling, vaccinations, and more the holistic care. So the other facilitator is, as I mentioned, training. So people, if they feel that they are well trained, then they can kind of deliver the STI services. And also having consistent guidelines. As you saw, my slide shows that, there's very different screening frequencies. So we need something to be a bit more consistent, and WHO is going to help with that. The other diagnostic kind of facilitators is I'm doing another systematic review at the moment with WHO looking at the pooled sampling. So rather than testing like the 3 anatomical sites, you can actually take all the samples and put it into one vial. And so rather than triple the costs, you can kind of reduce the cost just in one sample. So that's quite a cool idea. And we'll just to let you know that it's very effective. So it's got high sensitivity and specificity. The other nice thing is around self-sampling kits, which is also under development. And this was another idea from an implementer that talks about, if you can tell us what diagnostics to use, like the cost, the turnaround time, and so on, this might make it a lot easier for us to actually start implementing. And also, I guess, more research for better, cheaper STI diagnostics, and also drug regimes as well would help. So I'm going to end by just summarizing the key messages from our review. So I think the first key message is that these are incredibly high burdens of STIs, of people coming in for PrEP. And I think sometimes looking at the numbers, it kind of just loses its effect on us. But as I tried to give you a reference point and just show you how much higher the rates are. But yeah, they are very, very high. So so this is just the numbers just to reflect how much higher in magnitude are the people using PrEP. And this one is the one for incidence as well. And just a note here, I didn't highlight this at the bottom here, but if you're thinking about new incidence, say this statistic here is at 72 per 100 person years. So essentially 3 out of 4 people within a year would have a STI. So that's, again, just to show you how high their risk is. My other key message is that given these really, really high STI prevalence and incidence, we actually do have an opportunity. And this is a message that I want to kind of hammer into you. So if you forget everything else, this is probably one of the major ones. It's that PrEP is actually attracting the right people in terms of preventing their HIV risk. But at the same time, we are capturing people that have very high STI risks as well. So we do need to kind of help them with not just the HIV side, but the STIs. And so providing them with kind of basic STI services, to me, is essential. Otherwise, we're kind of swapping one pandemic for another pandemic, which are the STIs. So PrEP programs are an opportunity for supporting really comprehensive STI services. And it's more than just the STI testing and treatment. So I think there's a lot of opportunities for economies of scope here. So in terms of implementing vaccinations, reproductive health things, and more holistic services as well. And it is largely happening in a lot of high-income countries, but we do need to kind of, I guess, help the ones that are the ones that are bolting on or separated, that we need to help them integrate STI services a bit more. So finally, yeah, PrEP programs is a gateway, I think, for empowering comprehensive sexual health services. For those who want to read the paper itself, so it is open access. So you can find it in this, searching for this title. And thank you very much for your time. So I will stop sharing and see if there's any questions from the audience. Thanks.
Hi, Jason. Thank you so much. That was really interesting and a really great summary of a paper that's got a lot of stuff in it. So you did a great job of distilling that down and focusing on the key points. So I will make sure I've got the chat open on my screen in case anyone has any questions. Please feel free just to put them in there. And either I can convey them to Jason or we can read them out. But just while we're giving people a chance to do some typing, you mentioned at the end a question which sort of came up for me through your presentation, which was around, there was a sort of seemed to be a focus on using PrEP as an opportunity to test for STIs. But I was wondering if there are programs which are using it not so much, I mean, obviously testing for and treating current infections is important, but also an opportunity for perhaps education or preventative strategies to really try and reduce the incidence of new infections going forward. Is that something that's being looked at as well?
Yeah, definitely. So we tried to capture some of that in our review as to how much counseling, extra counseling was being offered, but we found it quite difficult to get that measure. But in terms of standard practice, I mean, in most PrEP clinics in Australia, I'm speaking of, we will counsel everyone about STI prevention. So we're hoping that it happens, but I think around the world, it might be a kind of an assumption that may not be true. I guess in a lot of the PrEP programs may not even talk about, you know, how do you actually reduce your chance of STIs, and in terms of using condoms or reducing partner change. So it's definitely more than just about testing. It's kind of, you want that more holistic sexual health services for them. Yeah.
Okay. And I mean, I think the other really interesting comparison there was between the sort of high income and the lower income countries. I mean, you mentioned that you've got the results in the appendices of your paper, but we've got a few minutes. So was there some sort of key messages coming out of there that were particularly of interest?
So there was some shockingly high STI incidence and prevalence amongst the adolescent girls and young women. So I didn't really highlight that in my talk today, but that's another thing that's really emerging from a lot of other recent research as well, to show that, you know, we have always been focusing on MSM and saying that, you know, they have really high risk for HIV. But actually in low middle income countries, it's actually the women, and it's the young women that really we need to focus more resources towards. So when I first saw that data, I was quite shocked to see, are these actually outliers, or were they real STI incidence and prevalence? So I actually reached out to each of those settings, and they told me that this is reality for them, and they're seeing so much STIs. So that to me highlighted, yeah, it's kind of uncovered a different pattern that we try to now focus more attention on.
Because I can imagine that the strategies that might address the underlying sort of reason for the high rates of infections, and then also how you deliver treatments and the types of programs that you would implement would be different, because they're quite different populations.
Exactly right. Yep.
Okay, sorry, I've just realized I had chat open but not Q&A. So there's a question in the Q&A from Juliana. Jason, could you please comment on the time frame for measuring the incidence of new infections among people on PrEP compared to what you presented in the general population?
Yeah, that's a really good question. So I think this kind of leads to the kind of the bias whereby, because we are testing like every 3 months in PrEP, so it will kind of artificially inflate our numbers. I guess even if you halve that, or even have a quarter of that incidence, it's still going to be an elevated risk of incidence amongst PrEP users. But you're absolutely right. I think that's that is one of the limitations of our study, is that there are different timeframes or frequencies of testing for people in PrEP versus those who are not in PrEP. So that definitely influences our numbers.
Okay. Were there any other questions from the audience? If not, I'll just ask one more thing about. So I was quite interested in that idea of kind of pooling of the STI samples and the potential for that to sort of reduce the costs of STI sort of testing and services. Do you want to just talk a little bit more about that?
Yeah, for sure. Yep. So I mentioned that we are actually at the end of doing a systematic review at the moment. So we are looking at the performance of these. So if you imagine a man coming in and they've got 3 sites that they need to swab. So when you run it through the machine, you need to run it through 3 times, and the cost is X amount. But the idea is, rather than having 3 samples, we take the oral swab, the urine, and the anal swab, and we put it all into one vial. And so the cost is only just a 1 test. And so theoretically, that reduces it by 1/3, roughly. And so that might help, I think, with a lot of STI testing where cost is a major barrier. And encouragingly, we find that it's very high sensitivity and specificity. So in the realm of, so the pooled sensitivity that we found for chlamydia at least was around 95%, and specificity was 100%. So it's well above the kind of targets that WHO wants for this. So this will hopefully be published very soon and influence their guidelines as well. So I think this is one thing that WHO wants to put into their STI guidelines, that this could be a viable option to pool the STI samples.
Oh, that's really interesting.
Yep.
Okay. we're nearly out of time, so I'll just give everyone a few more minutes just in case there are any other questions coming up. And while people are typing, just say thank you so much, Jason, for presenting. That was really good, and definitely a paper that was well worthy of the Early Career Researcher Best New Paper Awards last year. A reminder that if anyone who's either listening live or on the recording isn't a member of the association, to check out the website, because there are a lot of opportunities such as these prizes, the webinars, the conference, which are available to members. And speaking of the conference, as the conference convener for this year, I'd really encourage everyone to put it in your diaries, 1st to the 3rd of December in Sydney, face-to-face. Who ever would have thought that we'd all be missing stale conference sandwiches and awkward chit-chat at morning tea? But if you, like me, have been missing those, then come along to the conference. Abstracts are open now. There's open for another 3 weeks. So if you've got some research like Jason's that you'd like to present, then definitely consider putting in an abstract because we'd love to see you there. I haven't got any other questions in the chat or the Q&A. It was a really clear presentation, so I can see. But definitely read the paper if you would like some more information, or I'm sure Jason would welcome people getting in touch if they have any further questions.
For sure.
So thank you everyone for joining us. Sarah, did you want to do any wrap up at the end?